Orange drink. Grew up there. I've been here over 40 years. Most of my life here.
There was another lady that was here. She is.
I lost someone. Okay. What you said then? Good evening.
Yeah.
How are you guys doing today?
Good.
Good. So, thanks for taking your Wednesday night to spend the night here with us and talk about some balance disorders. So, balance disorders are something that I know a few of us are pretty familiar with. So today we're going to talk about and uncover some of the layers between the different types of balance disorders and go through what methodologies and what things are most effective for them when we start to have some of these disorders and they start to become chronic issues. So we'll cover a lot of that today, and we'll talk about some of the things that we are able to do and some of the things you can do at home to help make these things more of a thing of the past. So what are our objectives today? Today we're going to understand the different types of dizziness. We're going to try to figure out, is your diagnosis correct? Because we're going to find out that balance disorders and vertigo tend to be one of the most misdiagnosed things in the health profession. We're going to talk about fixing balance by fixing the brain, and we're going to talk about how dizziness and balance problems can be fixed using some of the rehabilitation methods that we do here in this office. So what is a vestibular disorder? So when people talk about dizziness, usually it's a problem affecting a system in the body called the vestibular system. And a vestibular disorder are conditions that affect the body systems that control your sense of balance. So it's things that allow us to be able to walk straight. It's things that when we run or jump, that the world is moving around us, but we're still able to keep a steady sense of the world, and we can make sure that the world makes sense to our brains. And some statistics on this, about 1/3 of people over 40 will experience a vestibular problem at some point in their life. Usually these vestibular problems are pretty minor. They'll feel, when they turn their head, they get a little bit dizzy. When they stand up too fast, they'll get a little bit lightheaded. So a lot of people are going to experience this, but most people aren't going to experience the level of chronic dizziness, where dizziness tends to last for weeks or sometimes even months at a time. This number jumps up to about 80% when people turn 65. So when people turn 65, just like aging tends to make us feel beat up and hurt and sore, and aging just tends to make us feel pretty lousy overall, it also affects our balance pretty heavily. It's because the same nerves that go into our inner ear, they start to break down at the same rate that other parts of our body break down. Now, here's the good thing about it. Just like there are ways that as we get older, we can still maintain the health of our bodies from a musculoskeletal standpoint, there are ways that we could actually train our bodies to maintain better balance throughout our lives, and we'll talk about some of those methodologies a little bit later on. The actual vertigo, classic dizziness, where the world is actually spinning, is responsible for about 4 million emergency room visits per year. So a lot of people are going to the ER whenever they're feeling dizziness. And first, we'll go into a little bit why that's probably a good thing that some people do go to the ER when they have that sense of spinning. So, biggest thing that we have to talk about is, what do you mean by dizzy? Dizziness means a lot of different things to different people. So for some people, when you say the word dizzy, it means that the world is spinning or you're spinning around in the world. For some people, it means that things are rocking from side to side, or things just are moving and you know that you're standing still, but you feel that the world is kind of moving around you. It could also mean, some people when they describe dizziness, they just mean they're feeling a little bit lightheaded. So when they get up too fast, nothing's moving, but you just have this fog that's coming over you because you feel a little bit lightheaded. For some people, it just means disoriented or confused, or they don't feel anything moving, but they just kind of feel lost in space, where your memory just goes away for a moment in time and then starts to come back. So this happens to some people when they go into open spaces, and then their memory, their attention, their focus is everywhere except for the world around them, so they feel disoriented. It could mean foggy-headed, and for some people it just means that they feel some blurry sensations whenever they look at things too quickly, or it means that they have some visual disturbances, like they start to have some double vision. So finding out what dizziness means to you is the most important part in figuring out how to solve that dizziness. And the worst case scenario is when dizziness means it's an emergency situation. So when does dizziness mean an emergency situation? So our emergency situations tend to be, the biggest thing is stroke. So stroke, dizziness tends to be one of the hallmark signs of dizziness. And when you feel dizzy for the first time in your life, you never had dizziness before, and that comes with neck pain, the worst headache you've ever experienced in your life, you start to feel some slurring in your speech, or you start to have double vision, then those are the times where you don't pass go, you go straight to the emergency room. So getting to the emergency room, just make sure that you don't have a stroke, because as we all know, when it comes to stroke, the difference between getting to the emergency room a couple minutes later could be the difference between having full mobility in your leg or being partially paralyzed. And the longer that process goes on, it could actually take the life of someone. So this is something that we should take seriously. This is one of the things that we screen for on all of our dizziness patients too. It's why when we go through your health history, we're saying things like, you have a really bad headache with this, are you slurring your words, do you feel part of your lips drooping? So these are things that we have to rule out in order to make sure that your dizziness isn't something serious. If it's not something serious, worst case scenarios, you go to the emergency room and you feel, they just say, all right, you just have regular vertigo, great. You don't have a stroke, and you might have wasted a little bit of time, but wasting a little bit of time is a much better scenario than missing that diagnosis and having a large compromise to your life as a whole. So different feelings may have different causes. So for some people, the problem is lying inside their eyes. Sometimes people's eyes are moving way too quickly and it's not able to lock onto a target. For other people, your foot and ankle is a problem. So when you have poor balance and your foot and ankle isn't getting signals into your brain effectively, then they're going to feel off balance all the time. They're going to feel like they're stumbling and things are going to be off kilter there. For most people, the inner ear is a big problem. So when their inner ear is a big problem, then that's where you're going to have a lot of that spinning and rocking sensation. And for some people, it's actually affected at the level of the brain and the central nervous system. So when the brain is the problem, then that can really make the waters muddy. And we'll talk about how we can differentiate through a lot of these different symptoms. So understanding the cause of your dizziness. So if you have spinning and rotating, so that is your classic vertigo. When people are spinning and rotating, you feel the world spinning around you, that is your classic vertigo. How many people have had vertigo before? Yeah, quite a few of us have vertigo before, because vertigo, we'll see in the next slide, one of the most common causes of vertigo is something that's really pretty benign. It doesn't really cause long-term chronic problems. Some people will feel it for a day or two and never experience it again. Hopefully, if we ever get vertigo, that's the type of vertigo that we get, because those are types that are generally easy to fix. The offending piece of anatomy with that rotating vertigo is this piece of anatomy. It's called your vestibular apparatus. So this is what's inside of your inner ear. It's inside of an organ that's about that big. So an organ this big can create massive havoc inside of your sense of the world. So over here is something called the cochlea. That's the thing that we use to hear. So whenever you have deafness or problems with hearing loss, that means that that part called the cochlea is being affected. This part over here, called the semicircular canals and the vestibule, that's where we feel a lot of these balance problems start to kick in. So your classic vertigo problem is called BPPV. It's called Benign Paroxysmal Positional Vertigo. That means whenever you move the wrong way, you start to feel the world spinning. For some people, it means turning their head to the right. Some people, it means lifting their head up. And when you do that, you're shaking up these little crystals inside of your ears. So those crystals are called otoconia. So you have these crystals inside of your ear, and that's what allows you to, when you move your head to the right, the crystals move, they move these hair cells, and it tells your brain, all right, my head's moving to the right. When these crystals misalign and they go into a part of the ear that it's not supposed to, then it starts firing different receptors in your ear that tell your head is moving. So for example, if I have a crystal that's misaligned my right ear, I turn my head to the right, then those crystals move and it hits the little end receptors, and it tells your brain, oh, my head's moving really fast, so I better move my eyes really fast to try to keep up. So when your eyes start moving really fast, then it's going to create the illusion that the world is spinning around you, even if all you did was just turn your head a little bit to the right. It's characterized by brief moments of dizziness. So this is the dizziness where it lasts for 30 to 60 seconds, and then it goes away. You feel okay for a while, but then you move your head again, and it causes 30 to 60 seconds of vertigo again. And it becomes a hassle because you almost develop this sense that you're afraid to move your head in a certain way because you don't want to have that sense of vertigo. Because why is that? Because your brain hates being dizzy. When you get dizzy, you get nauseated for a lot of times. When you get dizzy, you start to feel like you have a hangover. You almost have this headache type sensation because your brain hates it when it can't perceive the world accurately. So that's what happens with this type of vertigo. Most cases can be treated with positional maneuvers. So this type of vertigo, even though it's pretty inconvenient, if it's diagnosed correctly, usually you do something called a positional maneuver, and it actually fixes the vertigo pretty fast. So this is the clinical sign of it. It's called nystagmus. So if you see people's eyes and they're starting to move around really quickly, that means that their brain thinks the world is moving around it, so it's starting to move the eyes to try to catch up with it. If you see signs of nystagmus, it's a sign that you have that positional vertigo. How do we test for it? We do a test called the Fixhull pipe maneuver, and people hate this maneuver because sometimes, and we actually have to keep a trash bucket whenever we do this maneuver to people because we do this maneuver, it's going to make you feel really dizzy, and people can sometimes puke immediately right afterwards. So basically, we're going to try to find which side of your inner ear is the offending problem. We turn your head and we drop you onto your back, and we see if that nystagmus starts to pop up. If that nystagmus pops up, that's a positive test. You know, even though it makes you feel pretty crummy, it's usually a good sign because that means we could actually treat the vertigo pretty effectively by doing one of these positional maneuvers. And what does that maneuver look like? So basically, you're going to turn your head, and then we're going to move your head in different positions. And the design of this maneuver is to get those little crystals to go back into the place where they belong, instead of having those crystals sit in the part of the ear where it's going to create havoc. So that's called the Epley maneuver for most cases, so you might have heard of the Epley maneuver. And there's a wide variety of alternative maneuvers that accomplish the same goal. Meniere's disease. Meniere's disease is a pretty rare disorder. It's what happens when you have this big buildup of fluid inside of the inner ear, and it starts to clog the inner ear. And when people have this, they have multiple signs. Not only do they have vertigo, but they'll have vertigo with a sense of ringing inside of the ears. So that ringing inside the ears is called tinnitus. Tinnitus, you'll have this persistent ringing in the ears, but beyond the ringing in the ears, you'll have this sense of fullness, like the ear is clogged up, and they'll actually have hearing loss. So if you have hearing loss with all these symptoms, then you have a likely diagnosis that you have Meniere's disease. Meniere's disease, the cause of it is still pretty debated, and it's really reluctant to certain types of treatment. But one of the things that we have seen is the type of chiropractic that we practice here with upper cervical chiropractic shows a really, really good positive response to it. And actually one of our best testimonials that were written about vertigo for us was from a patient that had Meniere's disease. So the clinical signs of Meniere's disease, when you have an attack of dizziness, ringing, and hearing loss, and it lasts for 20 minutes up to a couple of days. So a lot of people with Meniere's, especially in the early phases, if you just started having it, you may have these attacks that last 2 to 3 days, sometimes up to a week. The longer that you have it, your ear starts to try to block those signals, so you might not feel the intensity quite as bad, but that also means you're progressively losing more hearing and you're losing more function inside that vestibular system. So when you start to progress that far down the line, then sometimes the hearing loss and those vestibular losses can be permanent, so we try to catch it sooner rather than later. So when you have these signs, these flare-ups, it can be followed up with periods of remission, so it'll go away for a little while, and then out of nowhere it'll start to hit you again with that really bad vertigo and hearing loss again. So some of the studies on it, we actually wrote up a case study on one of our Meniere's patients who had a 60% return in their hearing after 2 months of getting upper cervical care, and his dizziness completely went away afterwards. So while Meniere's disease tends to be untreatable in a lot of the medical circles, we've had a pretty good success rate here with these types of cases. There's another case study on 300 consecutive patients with Meniere's followed over 6 years, and about 97% of them showed a pretty substantial improvement in their vertigo. and many of them got some of their hearing and ringing symptoms decreased as well. The other symptom that we don't really deal with quite as much, but it's called vestibular neuritis or labyrinthitis. It's when you have an infection and it gets into and infects the inner ear. A lot of these times these are caused by viruses and it affects a nerve called the vestibular nerve. And when that nerve gets affected, it mimics a lot of the stuff that happens with BPPV. So you'll get that vertigo, you'll get the nystagmus, and it can last days, and it's usually self-resolving. You might have hearing loss and ringing if it affects the entire vestibular organ, but that one's a little bit more rare than a regular case of neuritis. So those typically follow a course of an ear infection or an earache, or sometimes if you have a bad case of the flu, the virus gets and spreads up into the inner ear, then you'll get an infection and cause those symptoms there too. These are the cases where medications are probably in your better interest because these are going to resolve on its own. But in the process of resolving on its own, you don't want to feel like crap, right? Because when you have this, you try to get rid of that feeling as soon as possible because no one wants to feel nauseated and, like garbage for days and weeks at a time. So these are the times where getting some of these anti-nausea, anti-vertigo medications can be really useful. But for those other types of dizziness, taking some of these medications will actually prevent your body's ability to adapt towards your imbalance. So while they might make you feel better, feeling better in the long run decreases your ability to adapt. If you can't adapt to it, then over the long run, the effects of the medication might wear off, but your balance never actually improved. So that's why we say unless you have vestibular neuritis or a condition that is not fully treatable, we don't usually recommend getting this unless it's one of those acute attacks and situations where we don't know what the cause of it is. So these are the situations where medications are probably going to be in your best interest. Alright, so what if you have the rocking and swaying type of dizziness? Who's ever felt like they're gone and they feel like they're rocking on a boat and not necessarily spinning type? So we see a lot of that in our office and less so in the spinning type cases, so we're going to get into that a little bit. First one is called Debarquement Syndrome. So this happens when people go on long airplane rides or they're on a cruise ship and they step off the cruise ship and they feel like that the world is still rocking. Has ever felt that before? I've ever been on a cruise, I'll feel like this for maybe a day afterwards and then that feeling goes away. There's a small minority of people who will have this condition where they'll go onto a cruise ship and then that feeling of rocking just never goes away. They'll have that feeling for months, sometimes years, and it can be pretty debilitating when you feel like the world is rocking around you. The problem with this is that a lot of the tests that we'll usually do will show up negative. So you don't see that nystagmus, you don't see any of the obvious signs that we would look for with a true case of vertigo, but most people will have these symptoms and their doctor may misdiagnose them and say, oh, you have vertigo. But what we just learned, vertigo only happens when you have that spinning, right? But we've taken care of so many people here that have been diagnosed with vertigo, but they don't spin. They're just rocking back and forth, and they're not actually getting the accurate diagnosis. So what happens? When they get the wrong diagnosis, you start getting the wrong treatment. So they'll start doing that positional maneuver on these patients with rocking and swaying, but that maneuver isn't going to do anything because the actual cause of their symptoms hasn't been addressed. So this is one of the conditions that people generally find really hard to treat because so often it gets misdiagnosed. So what do we look for? With this specific type of dizziness, we're looking at their eyes and we're looking at their overall sense of balance. We want to see how are they rocking. And we'll put a test in front of people where we'll get them to stand with their eyes closed and we see which direction are they rocking, because sometimes that could be a spinal related issue. And we'll look at their eyes, and if they see that their eyes are misaligned, so one eye sits a little bit higher than the other, that indicates that the part of their inner ear called the otolith is actually malfunctioning. So if their eyes are perceiving the world like this, then all of a sudden this is their perception of the world, and this is their perception of the world, then they're going to try to rock and move in a way to try to get their world to straighten out again. So by figuring out exactly what's triggering this sense of rocking, then we can develop effective strategies to address that. And one of the strategies that we use is a technique called functional neurology. We'll figure out which ways are your eyes moving, and by figuring out which ways your eyes are moving, we could give you targets to look at and stimulus to look at to try to make your eyes move correctly again. So we'll use these techniques where we'll have you tilt your head and follow a target, or we'll have you tilt your head and look at a moving screen, and we'll have you do that for 20 seconds on, 20 seconds off, and then we're training the brain to readapt itself to what straight is. Because if your head is tilted like this, if we give you stimuli that can actually make you get your head up again, then all of a sudden the world's going to seem like it's not moving quite as much anymore. So we use eye exercises with head tilt, we use background stimulation, and then there's actually developing technology using virtual reality to help a lot of these cases of vertigo using that virtual reality type systems. Now, my favorite type of vertigo, because it's the easiest one for me to take care of, because as an upper cervical chiropractor, we take care of a lot of neck issues. So this type of vertigo is called cervicogenic vertigo. Cervicogenic just means the neck. So vertigo coming from the neck usually feels like an unsteadiness or an imbalance. So when you feel like you're just not really walking straight, you're not really moving, but every step that you take just feels a little bit insecure. It feels like if you go into open spaces, you're not really sure what to do because you want to reach for something to try to stabilize yourself. So things get worse with a little bit of neck movement, and sometimes there's neck pain in your history. This type of vertigo is really common after whiplash, after head injuries, things of that nature. And we can test for it really easily by seeing what your eyes do when your head moves. So if I turn your head to the right and just have you follow my thumb, we'll actually see that your eyes won't follow smoothly. You'll actually start to jump to try to catch up with targets. And some of you might have felt that when I was doing those exams with you. If we see that, and then we adjust your neck and we see that that phenomenon goes away, then we know you have cervicogenic vertigo, and that correcting the head and neck was actually going to be the best mode of therapy for you. If you have lightheadedness, so lightheadedness is usually when decrease in blood flow to the brain. If you have decreased blood flow to the brain, then you're going to feel you get up too fast and it feels like the world is darkening around you a little bit. And this causes of it are low blood pressure. So a lot of people know that high blood pressure is a really bad thing, right? But for people with low blood pressure, especially once we get past the age of 65, having low blood pressure could be just as detrimental for you, because what's one of the number one causes of death in people that are 70 and older is going to be falls. So when you fall, you break your hip, and you break your hip, you go to the hospital, you catch pneumonia, it's a thing that leads to a whole series of other problems. And a lot of people are falling because they get lightheaded, and when they get lightheaded, they might faint or pass out, and then they'll break a hip that way. So that's one of the big reasons why low blood pressure can be just as a significant problem for older people as high blood pressure. Another thing that can happen is a condition called dysautonomia. So dysautonomia is when the brain and the heart are on two different wavelengths. So your brain is demanding, this much blood, and the heart's only able to give it this much blood. If those don't match up, then your brain is going to kick the heart into overdrive, and it gives you things like rapid heartbeat, or if the heart can't keep up with it, then it creates this condition called hypotension, where you want to faint or collapse. And we test for that using a test called the table tilt test. It's a really brutal test for people that have dysautonomia, so they'll start tipping them back and their heart rate starts to jump up to 150, 200 beats per minute. It feels like they're having a panic attack when you're having this type of problem. We could also do seated, standing, or lying down blood pressure checkups. So one of the things that people don't really check for too often is they'll check your blood pressure with a seated position, but what happens to your blood pressure when you're standing? It's supposed to go up a little bit. If it doesn't go up, then that's a problem. It means that your heart didn't tighten your arteries to get blood flow to your brain. That may make you feel faint and might make you pass out. And we also do proprioceptive and vestibular testing with this too. Things that address the autonomic nervous system are really important. So upper cervical adjustments are really good, and eye exercises are really good at generating blood flow to targeted parts of the brain that tend to be deficient in these types of conditions. Then we have other conditions that cause vertigo. You have chronic problems from strokes. So if you have had a stroke, a lot of people with strokes have a lot of problems with balance issues. Concussion and whiplash is probably the number one place where most of my dizzy patients come from. So whenever you have a concussion, it knocks those crystals out inside of the inner ear, and it also injures different parts of the brain that are responsible for controlling your sense of balance. We also have diseases like MS and migraine that can cause vertigo too. that's related to blood flow in the brain. So all of these have in common is that they affect very specific parts of the brain. So they affect the parts of the brain that help to control your eye movements. So those parts of your brain might get affected, and then your eyes can't move appropriately to the environment around it. It might also affect parts of your brain that control the autonomic nervous system, like the midbrain. So that gets affected, and your heart rate can't keep up. Or it controls the part of your brain that hits, called the cerebellum, which controls your general sense of balance. So how many people have ever had a sobriety test, ever gotten pulled over and had a sobriety test done to them? Oh, we got a pretty good crowd that doesn't drive recklessly at night. Well, that's good. So if you know some of the classic sobriety tests, they'll have you stand and they'll have you touch your nose, they'll have you close your eyes, they'll have you walk on a straight line, end to end on one foot. So that part that they're actually testing is called the cerebellum. And a lot of people do these cerebellum tests because alcohol hits that part of the cerebellum pretty fast, and it makes you feel discoordinated. So that cerebellum can also be injured from brain injury, from concussions, and it can also be affected just from not moving very much. So if you're sedentary, that part of the brain starts to become less active, and it becomes less active, then your balance becomes less effective too. So when you have these central vestibular dysfunctions, the problem with that is all those conditions we talked about earlier, they all tend to hit a part of your ear called the vestibular apparatus, and all those types of vertigo and dizziness, they play by a very straight set of rules. So if I do the Dix-Hallpike test on you, you have BPPV. I do a Epley maneuver on you, then you're fixed. And those are easy cases, and they're very straightforward. When it comes to some of these secondary vestibular issues, when they're affecting the brain stem, they don't play by those same rules. All your symptoms can start to overlap. So you might feel a little bit spinny sometimes, you might feel like you're rocking sometimes. So because they're not playing by the same rules, they make them a lot harder to effectively diagnose, and that makes it a lot harder for you to treat. So when you have these conditions, a lot of conventional medical procedures aren't well equipped to address these issues because they're not looking at what parts of the brain might be affected and how to rehabilitate those parts of the brain so you can get your balance back. So we look at the brain and try to figure out, all right, you have your ears, you have your eyes, you have your muscles, and you have your brain. And you have to figure out which parts aren't working well. And if we can identify which parts aren't working well, then you can give you the effective treatments or therapies to try to elevate the effectiveness of that system. So if the problem's in your ankle, and your ankle is responsible for giving you balance problems, then we have to look at the ankle and do an intervention with the ankle in order to make sure that you're getting proper stimulation from that joint. If your eyes are a problem, then we have to look at your eyes and we have to figure out how do we get your eyes to become stable. If it's your inner ear that's a problem, then we have to figure out what can we do to movement of your head to make those areas stable. So this whole concept is called sensory integration because you're getting all these multiple senses coming into the brain. And your brain has to decide, how do I prioritize which information is most important? And when we can make all of those senses say the same thing, and that's how your balance problems become a lot better. So it's called a mismatch problem. So it's not a mismatch like these mismatched clothes. It's not a mismatch like the sumo wrestler against a kid. It's a sensory mismatch. So it means that what you perceive as reality is different from what is reality. So if your body feels like it's on a boat, but there's nothing that's moving, then that's a sensory mismatch, and that drives your brain crazy. Your brain hates this a lot. And that's why it causes nausea, that's why it causes all these other problems besides just the dizziness itself. So our job is to make sure that all these senses say the same thing all the time. So treating dizziness, you have your textbook dizziness. So when we learn about things in the textbook, and this is how most things are done medically, is people with dizziness and balance problems should fit neatly into a diagnostic box, right? But the truth of the matter is, people don't follow the rules that it says in the textbook. The textbook is meant to give you a guideline of what to look for, and then when you follow those guidelines, then it gives you a general idea where to go. But the reality of dizziness treatment is lots of people fit in diagnostic boxes very messily. So a lot of people may have a little bit of spinning, some people have the rocking, and some people may not have any of those types of things, and they can't even describe what it feels like when they're dizzy. So if they can't describe what it feels like when they're dizzy, then we have to do our best to try to figure out what they might be talking about. So when people treat things like a textbook, that means everyone gets a cookie-cutter treatment for the dizziness based on the diagnosis. So a lot of people that may have gone to vestibular rehab, they'll put a dot in front of them and they just shake their head at the dot for 15 minutes and say, all right, you're fixed. But in reality, they might not have hit the right system that was responsible for causing their vertigo. So we can't treat all these dizziness patients like they're the same, because some dizziness patients may need that head shaking maneuver, some of these dizziness patients may need a treatment on their neck, some of these dizziness patients may have an ankle issue. So we have to try to figure out what things are contributing to this problem and address all of the senses and not just one like it exists in a vacuum. So how do we fix this? We identify the contributors to your dizziness using a neurostructural exam. So we look at the top of the head and neck and see if that's a problem. We look at your eye movements and see if that's problematic. We do vestibular proprioceptive testing to see if your muscles and joints are giving you the right information. And we do some dynamic posturography to see how you hold your balance. So once we find it, then we're able to create a system for correcting it. So most dizziness problems all come into one part of the brainstem called the vestibular nucleus. And the vestibular nucleus is super complicated. So I'm reading about it now, and it can be overwhelming to understand how many senses actually come into this nucleus. And the job of it is to act like a calculator for your sense of balance. So it has to decide, all right, inner ear, am I going to the right? Eyes, am I going to the right? Neck, am I going to the right? If everything says it's going to the right, then everything's all good. No problems are happening. But let's say that your inner ear says your head's moving to the right, your eyes says it's going straight ahead, but your neck says it's going straight ahead. Now it has to wait, all right, my eyes and my neck say I'm going straight, but my ear says I'm going to the right. So it has to decide, do I listen to the eyes and the neck, or do I listen to the ears? And if it makes the wrong call, that's when we start to feel that sense of imbalance. But if it makes the right call, then you can adapt to it and have compensations. Because some people will lose all their vestibular function, and they'll still be okay because their ankles work well, their knees work well, their neck works well, and their eyes work well. So they have that to rely on. But when they're saying different things, then it creates a big problem for the brain. So by knowing this, then we know that, all right, we could use different systems of the body to try to figure out how to correct that imbalance. So by identifying the offending body part that's messing up the vestibular nucleus, then we can stop the sensory mismatch. And this can be done by adjusting the neck, it can be done by adjusting the jaw. For some people, by just getting them to exercise and move, it can be fixed, or by addressing a therapy to the inner ear. So here are the tools that we use. We use the NUCA correction, we use head and neck vestibular exercises, we use very targeted head position exercises, and we'll use head shaking and eye exercises to address it depending on what's causing your sense of dizziness. So here's the important thing, the recipe matters. So how many people have ever baked a cake before? I've tried and I'm not very good at it, but from what my